So here's case 2. And this is, again, introducing this concept of treatment using a novel therapy earlier on. So here's a 67-year-old with a PSA of 120. He presents with metastatic disease with multiple bone mets to the spine, left hip, and left femur, so 3 bony mets. He also has some lymphadenopathy, about 2 to 3 centimeters. Chest CT is negative. Biopsy shows Gleason score 8, prostate cancer, good performance status. Still just having some minor left hip. And I think that for urologists, at least until the PSA guidelines change, I think that this type of patient will be increasing in our clinics. So what are his options? Does anyone want to chirp in here and say something? Docetaxel. Androgen deprivation.
Androgen deprivation, possibly radiotherapy to the bony lesion.
Bony lesions. How about any of the new therapies? If everything was funded, maybe? Okay, Abby. And how about treatment of the primary disease? Okay. So for those on the internet, the different treatments were considered that androgen deprivation, docetaxel, and I tripped in positive local therapy. So this gentleman received androgen deprivation and docetaxel. You see the charted 6-cycle dosing. His PSA metered at 6.5, and then started to rise to 11 3 months later. So what would you offer this patient now? Let's pose it to the 2 panel members here. What would you have done initially back then? And obviously now with the most recent data, things have changed. What would you do now with this individual?
This is what we would have done there, and this is what we will do tomorrow morning.
Yeah.
So for now, this is I think the new standard of care for somebody who's healthy enough to get chemotherapy, who has this kind of disease with the extent of the metastases. I think the big question that you asked is, do we treat the local disease or not? And I just wrote an editorial on that. And I think that is still something up in the air, and I wouldn't encourage the urologist to start taking out prostate from this kind of patient outside of clinical trials. But that is still a question whether where do we draw the line in terms of local therapy?
Yeah, I would have done the docetaxel for this guy. What would I do tomorrow, though? Tomorrow, if he presents tomorrow, I would actually talk to him about abiraterone, whether he has third-party insurance, whether he can afford it, go through the pros and cons of docetaxel versus abiraterone. One of the questions is, do we do all 3? Do we give him androgen deprivation therapy plus docetaxel plus abiraterone? At this time, I would say no, because we just don't have the evidence, and that we may be just layering therapy without actually getting an additional benefit. Sometimes, 1 plus 1 plus 1 is not 3, and so we should be careful about doing too much to patients. We certainly can do harm.
Great. So I guess in summary, then, you're not going to be waiting for this official Health Canada indication. You'll be considering using it if it's fundable or funded third party.
Yes, I would, because Health Canada takes a year at least, and then all we could be 2 years into this. In the meantime, we're going to have lots of patients having lots of troubles, or we could have affected them otherwise. So we probably have about 250 patients in British Columbia. So if you multiply by 10, 2,500 patients across the country presenting like this.
Yeah.
And I think we need to do something about it sooner rather than later.
And Fred, I'm not going to put you on the spot, but one question for your talk is, do we have enough data with the MCRPC information and now the information with abiraterone to substitute Abby with EMSA in the hormone-sensitive patient, in this classic latitude patient?
So that's going to be the subject of my talk. So thanks, Alan. So this is really, I think, one of the most exciting times. I mean, we've lived through exciting times over the last 10 years, being able to offer new therapies for patients with castration-resistant disease. And the obvious next step is so what can we do more and what can we do better. So this is the clinical states model that we've been talking about ever since Prostate Cancer Working Group 2, looking at the patients that we see most often that are still clinically localized, the rising PSA, but eventually we either see upfront metastatic hormone sensitive, and eventually most of these patients will progress to the metastatic CRPC setting. And until the recent past, this was the standard of care of giving ADT for both the metastatic hormone sensitive and the metastatic CRPC. And over the last 10 years or so, the options beyond ADT in the metastatic CRPC setting have grown, and Kim covered a lot of the issues of sequencing regarding these different therapies. And I would continue to highlight that the bone-targeted therapies, in terms of not improving overall survival, still play a role in terms of controlling and maintaining the bone that needs to live through all these therapies that we try to offer patients. So this was the first result of any drug that showed an improvement in overall survival in the mCRPC setting, with about a 3-month improvement in overall survival with docetaxel compared to mitoxantrone. And already there, the hope was, well, if it works in the very worst situations, would it make sense to give it upfront in the metastatic hormone-sensitive setting? And this was a slide that Chris Streamy had presented when he did the podium session at ASCO, that the hope was, if you've got a high burden of disease, you clearly have the likelihood of having a high burden of intrinsically resistant clones to hormones. And so that if you added docetaxel up front, you might delay the appearance of the castration-resistant setting and hopefully improve overall survival. So that was the rationale behind adding docetaxel up front. And everybody knows now that this has become the standard of care, because the improvements in overall survival are probably some of the most impressive of any solid tumor, not only prostate, when you go to a metastatic setting and improve overall survival by over 13 months. And the interesting points also that go in line with all of this is that not only was there an improvement in overall survival and nothing else made sense, you actually saw almost doubling in PSAs reaching undetectable levels when you added chemotherapy. You saw at 6 months and at 12 months that more patients were at undetectable PSA levels, so that correlates to better outcomes that was described in, several years ago by Maha Hussain with the SWOG study. And the median time to reaching castration resistance was also significantly delayed with the addition of docetaxel, and the time to clinical progression was also significantly delayed. So everything was going in the same direction, so it does make sense. And what is the most impressive of all of this is that these patients that started with only ADT did get chemotherapy when they became castration resistant appropriately. And so just delaying the intervention didn't allow catching up to the control arm, or to the combination arm. What's also very reassuring is that another study reported a year later almost identical results, that adding chemotherapy to ADT improved significantly the survival. And so when we put all of this together on one slide with all the advantages of overall survival in the castration-resistant setting in the range of 3 to 5 months, and then you look at using a drug that was effective in the castration-resistant setting and bringing it up to the castration-sensitive setting, then you jump to over a year advantage in overall survival. And so the next logical step was to include this in the guidelines and to say that now for metastatic hormone-sensitive disease, chemotherapy should be considered as a standard of care, at least for the high-volume population. There's still some controversy about the low-volume setting, whether docetaxel does make a big difference or if it's a different biology. So the rationale of bringing something that's effective in castration resistance to the castration sensitive setting makes sense. So why not consider bringing other effective agents in the hormone sensitive setting? And that is the basis of the Latitude study that was presented. So how many people were at ASCO this year of the urologists and doctors here? Right, that's what I expected. So this is why this session was organized, because many people don't go to ASCO that are part of the urological community. But this was one of the big highlights of ASCO, very similar to when docetaxel was presented at a podium session a few years ago. So Latitude is a phase 3 double-blind randomized study looking at ADT as the standard for high-risk metastatic hormone-naive patients. And you have to remember, this study started before Charted completely reported. So this was appropriate as a control arm. And it compared ADT plus abiraterone acetate in these high-risk patients with metastatic disease. So clearly the study design was not to include those low-volume, low-risk metastatic patients that we know do well with ADT alone. So these patients had to have either visceral metastases, Gleason 8 to 10 disease, and multiple bone mets to be eligible for this study. And the primary endpoint was overall survival and RPFS. And so to cut to the chase, why this was chosen as a late-breaking abstract to the full podium or plenary session was that there was a statistically significant reduction in the risk of death of 38%, which is almost identical to what was seen with docetaxel compared to ADT in the Charted study. So here patients, and you see that, look, I mean, the other thing that we learned from these studies is not only the differences, but look at the survivals of these patients. We are in 2017 and they're still living less than 3 years. So it just confirms that these metastatic patients are actually sometimes worse than our mCRPC patients that we capture early, that live clearly close to 5 years now when we catch them early, asymptomatic, with low PSAs, with no symptoms. We can almost guarantee patients that there's a likelihood they're going to live 5 years. You get this patient coming into your door. This is the first presentation of a metastatic patient, and that patient, all you can tell him is there's a likelihood he's going to live less than 3 years with ADT alone. So clearly, the biology is not, it's not because you're later in the disease states model that you obviously live less. There are heterogeneous populations. And so these patients have clearly, and Stampede reported similar results. So the median survival was not reached in the combined arm. So what about radiographic progression? Again, these things are aligned, and there was a 53% reduction in the risk of radiographic progression or death in the patients that got the combined arm. So it went from 14.8 months. So these patients, 14.8 months, have progression radiographically. We're not talking about PSA, radiographic progression, and this was more than doubled with the patients getting the combined arm. So when you looked at the improvements of all the secondary endpoints, they all lined up. And this is always very reassuring when all the primary and secondary endpoints point in the same direction. It's not a fluke finding because it makes perfect biological sense. This is probably one of my most striking results when I looked at this data, is in terms of PSA progression. So what makes us decide when somebody starts ADT to go on to AbbVie or Enza in the castration-sensitive setting? If they are upfront metastatic disease, it's PSA progression, right? So how long does it take for these patients to progress? 7 months. So we are getting this survival advantage by starting these therapies 7 months earlier than when they are actually Health Canada approved and in the guidelines. So think about that. We start a few months earlier, and we end up by improving overall survival by almost 1.5 years. So that is important. And these patients progress very quickly. So 7 months time to progression, I think, tells us that these patients need to be followed either closely or be put on other therapies beyond ADT. And in terms of progression of pain, patients are all worried about progressing in terms of symptoms. Here again, it wasn't reached in the combined arm, 16.6 months. Even though they're followed, they still progress quicker in terms of pain. Obviously, they're usually already on the second line of therapy when they reach the pain. And in terms of symptomatic skeletal events, this is reassuring because these are some of the events that we want to avoid. And so this is still, in my opinion, immature because a lot of these patients never develop the skeletal-related event because you have to almost follow them till death. we're talking about skeletal-related events, and we tend to say, well, this drug helps, so we don't need any other drug. But I think that's short-sightedness, because a lot of these events will actually still occur in the last year of life and won't occur while the disease is under control. But having said that, even in that endpoint, clearly. And the other things that we want to delay are the use of adding chemotherapy. And here again, it was statistically improved by 56% of going on to chemotherapy after having gotten ADT and abiraterone compared to getting ADT alone. And 58% of getting any subsequent therapy was also reduced. So you can stay on that therapy and control the disease for significantly longer. So these are all impressive in terms of efficacy. So what is the cost? And the cost is beyond monetary cost. Are we adding significant toxicity by starting earlier is always the question that needs to be asked. And clearly, we don't seem to be adding a huge amount of toxicity compared to what we already knew about this agent in the castration-resistant setting in terms of hypertension. Kim showed the results, and very similar in terms of toxicity, even though they're getting it a little bit longer than in the castration-resistant. And I say a little bit because when you actually look at how long the non-symptomatic patient getting abiraterone, it's not that much longer than in this study because of the survivals of these patients that are shorter than in the average low-volume metastatic setting. So in terms of safety, the ones that came out were hypertension and only required treatment, rarely required treatment discontinuation of AbbVie. Hypokalemia is still an issue regardless of when we give the drug and needs to be followed. And cardiovascular events were a rare event and didn't seem to be highlighted in patients getting it in this setting. So the conclusions of this study that were reported at ASCO is that it led to a significant improvement of our overall survival of 38% reduction in the risk of death and a significant prolongation of radiographic progression, and that the safety profile was consistent with MCRPC. So I'll quickly go over another study, and this is also something reassuring in oncology, is when two studies come out almost simultaneously saying the same thing, and what we don't like are conflicting studies. So the UK group reported on Stampede, that you all know is a huge study looking at different scenarios for patients with hormone-sensitive disease. So the inclusion criteria were any newly diagnosed patient with metastatic disease, with node-positive disease, or if they had non-metastatic disease but of very high-risk features. And high-risk features are T3, T4 disease, PSAs above 40, or Gleason 8 to 10. And you had to have at least two of those criteria to be eligible. So Stampede does include non-metastatic patients. So the characteristics of the patients that went into the study, half the patients were metastatic, 20% had lymph node only metastases, and a full 28% had no lymph nodes or no distant metastases, so had high-risk features of locally advanced disease. And so what did this study show? Again, significant improvement in overall survival in patients getting AbbVie plus standard of care versus standard of care alone, 37% reduction in the risk of death. So 38% in one study, 37%. You really can't ask for much more in terms of consistency. And the overall survival was pretty similar across the board, and where you see that it seems to be losing significance is actually in the non-metastatic setting. And so when you look at overall survival in the non-metastatic setting, it becomes non-significant, but clearly in the metastatic setting, it is significant, and overall it remains significant. In terms of the failure-free survival, so this would include progression of PSA, clearly an advantage of the combined arm versus standard of care alone. And again, in terms of failure-free survival or progression-free survival, there all the subgroups are advantaged by the addition of abiraterone. And so here, both non-metastatic and metastatic do benefit in terms of failure-free survival. If anything, it might actually be better in the non-metastatic setting. But be cautious, this includes PSA progression. So PSA, if the non-metastatic patients will have better responses to even ADT alone, and especially with abiraterone, we would delay the progression of PSA. In terms of skeletal events, again, here they confirmed, again, a reduction in skeletal events with the combined arm compared to ADT alone. And skeletal-related events in the metastatic setting was even more impressive in terms of reducing the risk. And what happened, and they captured what happened after they progressed in terms of new treatments. And so patients who got standard of care alone of ADT, there was a mixed bag of what they actually got. But obviously patients who were on the abiraterone arm more likely got docetaxel when they progressed. So just to end in terms of safety, very similar to the Latitude study, they didn't see anything striking in terms of safety. It's still hepatic issues and cardiovascular issues that come up, but not any different than what we would have expected in the CRPC setting. And so the authors concluded that in a hormone-naive setting, abiraterone acetate plus prednisone improved overall survival, failure-free survival by 71%, including PSA. Just this is the difference, and skeletal events by 55%. Was well tolerated, and they pushed the bar. The UK liked to come up with these kind of conclusions that it should be part of standard of care for men starting ADT. And this is a wide statement that probably we'll be discussing as to how early we should be introducing this therapy in patients. So what I would propose is that clinical states model I showed you earlier, that now with these two phase 3 studies that reported at ASCO, that clearly for metastatic hormone-sensitive disease, we now have, I think, two options over ADT, and that would include docetaxel and abiraterone. And as Kim mentioned, well, what's the next step? Are we going to be combining these therapies? And those studies are actually underway with combination approaches. And obviously, no surprise to anyone here, enzalutamide is also being studied in this setting of metastatic hormone-sensitive, apalutamide, darolutamide, and combinations, and earlier interventions in the metastatic and non-metastatic hormone-sensitive settings. So I'll leave it at that, and we'll let Alan take on the questions. Thanks.